of that work is focused on heart failure with preserved ejection fraction, including with cardiac amyloidosis. And he's received funding from the National Institute on Aging and the National Heart, Lung, and Blood Institute to support his research activities. He's published over 270 articles, including peer-reviewed manuscripts, reviews, and book chapters. He was the chair of the American College of Cardiology's Geriatric Cardiology Member Section, which is the largest organization dedicated to advancing the care of older adults with cardiovascular disease. He was the co-chair of the steering committee of the ATTR ACT trial, showing tafamidis was a safe and effective therapy for transthyretin amyloid cardiomyopathy, and really throughout his career, he's promoted an approach to older adults with cardiovascular disease that offers the best of both geriatric and cardiovascular medicine. So without further ado, thank you, Dr. Maurer, for being here, and welcome.
Thanks, Marty, and Dr. Feaster and all. It's a pleasure to speak to you. Sinai has a warm place in my heart, having trained there 30 years ago. Without further ado, this is obviously a rapidly emerging arena that is transthyretin cardiac amyloid and cardiac amyloid in general that I would submit has, in a brief period of time over the last decade, transitioned from a rare and underdiagnosed and past untreatable disease to one that's increasingly and easily recognized by any provider, assuming you think about it, and as I'll highlight, is quite treatable. So here are my disclosures. While I'm very excited about the emergence of these effective therapies, I think there's some caution out there because the cost is quite high and could pose a significant obstacle to widespread adoption, and we can touch upon that later. I am supported by the NIH and several pharmaceutical companies that have compounds in late phase clinical trials that I'll touch upon. So as you're all probably well aware, heart failure is this growing epidemic. About 7 million individuals now with heart failure in the United States, and lots of new cases, 1 million new cases, lots of outpatient visits. And if incident cases weren't enough, we put people into heart failure in the hospital all the time with iatrogenesis. And the reason I years ago became interested in heart failure is shown here, in which you can see that it's quite tied to the aging of the population. The rate much higher in those of Medicare age than others. And it's quite a costly diagnosis that I would submit we don't do a great job of managing. And Maggie Redfield highlighted years ago in the New England Journal of Medicine that if you were taking your board exam, for example, in the 1980s, the right answer on the boards was about a third of patients had HFpEF, or heart failure in setting of preserved ejection fraction. But over time, this has become the dominant form of the disease. And while we've done reasonably well at forestalling events with regard to HFrEF, HFpEF is taking off. And Sanjay Shah and others have highlighted that if we extrapolate these data over time, by far and away, HFpEF, or normal ejection fraction heart failure, will become the dominant form of the disease. And this is a pathophysiological, I would submit, conundrum. This is the paradigm. I just remind you that we were all taught in medical school, and I'll highlight, I think, some difficulties with it. So I was taught by Dan Burkhoff about pressure volume analysis as a junior faculty. So here I'm showing left ventricular pressure, obviously, on the y-axis, left ventricular volume, and here's the end-systolic pressure volume relationship and index of contractility, and the end-diastolic pressure volume relationship, an index of left ventricular filling. And as you can see, this is, if you will, a normal pressure volume relationship. And the pathophysiological paradigm is that changes with aging, hypertension, and concentric left ventricular hypertrophy result in upward shifts of the end-diastolic pressure volume relationship with minimal to no change in chamber contractility, such that left ventricular end-diastolic volume, shown here, is reduced, and accordingly stroke volume is reduced, and hence cardiac output is low. And so there's neurohormonal activation in an attempt to normalize, if you will, the stroke volume. What results is a left ventricular filling pressure that's significantly higher than normal at a volume that's significantly less than normal. And this is the paradigm that we were all taught and continue, I think, to promulgate. And I would just point out that there's, I think, a pretty big dilemma in this particular paradigm that we tried to advocate for understanding years ago. And these are seminal figures from the New England Journal of Medicine, Brunwald's Cardiovascular and Circulation. And I just point out that the dilemma here is that in every one of these pressure volume relationships, the patients are not hypertensive. And we all know that hypertensive heart disease is prevalent in 85, 90, if not 95% of patients with heart failure and a preserved ejection fraction. So I would submit that this classic paradigm may not be totally appropriate because the blood pressure is low. And I always tell the cardiology fellows that if you see someone with heart failure, normal EF, and they do not have hypertension, they definitely need to see a cardiologist. They have unusual diseases like precapillary pulmonary hypertension, constrictive disease or restrictive disease, or potentially either hypertrophic or infiltrative cardiomyopathy. And I term these true diastolic heart failure because heart failure, normal EF, and a low blood pressure tells you that the end diastolic pressure volume relationship is shifted upward and to the left. And in this circumstance, clinicians just integrate the EKG voltage with the wall thickness. And if it's increased and concordant, we can conclude the patient often has a hypertrophic cardiomyopathy. And if there's discordance, there's an infiltrative process. And I would submit that the pathophysiology of those with hypertensive heart disease is an area of obviously active investigation. And probably, as geriatricians talk about, HFpEF is a clinical syndrome with multiple diverse etiologies that need to be sorted out in order to arrive at effective therapies. So transthyretin cardiac amyloidosis, I would say, is the quintessential form of diastolic heart failure. Shown here, the left ventricular chamber is markedly reduced. You can see the atrium are almost as big as the RV and LV chamber capacitances. And this is a disease that results in progressive diastolic dysfunction. As you can see, upward shifts in the end diastolic pressure volume relationship are occurring over time here in a computer model, and the end diastolic volume is declining. As a result, the cardiac output declines, and so does blood pressure. And so this is kind of what we see in these patients over time. Classically, they present previously hypertensive, and you're peeling away often a lot of antihypertensive medications, which is concordant with this physiology. So years ago, as part of the development program with original company FoldRx for tafamidis, we conducted what was called the Transthyretin cardiac amyloid study, a small cohort study in which we showed that patients with this condition really have a rapid form of a cardiomyopathy with declines in 6-minute walk distance every 6 months that are concordant with what we see with the benefits of, for example, of a BiV pacemaker, increases in NT-proBNP that are quite dramatic, and declines in left ventricular ejection fraction every 6 months that are probably clinically impossible to measure in an individual patient of only 3 absolute units every 6 months. And notably, in this small study, the most important predictors of outcome here were how long people had the disease and what the output of the ventricle was, i.e. the stroke volume. Declines in stroke volume per ml were associated with significant increases in mortality. And the progressive nature of this disease was further characterized, as we've shown here, using data from the TRACK study and creating non-invasive pressure volume loop analysis. And as you can see, here are individuals at baseline shown in black, and over time there is an upward shift shown in the shift from black to blue in the end diastolic pressure volume relationship. There's a decline in chamber contractility and even an alteration in arterial elastance. And this results in marked declines in the isovolumetric pressure volume area and index of pump function, which is essentially the area between the end systolic and end diastolic pressure volume relationship. Interestingly, subjects who had the VAL122 ILE mutation did much worse than those with wild type disease. And this was only demonstrable by pressure volume analysis. Standard echocardiographic measures of mass and volumes didn't determine this. But as you can see, the allele carriers of a mutation had markedly reduced pressure volume areas at an end diastolic pressure of 30. And also interestingly, when we looked at those who lived, shown in black, versus those who unfortunately passed away over time, pressure volume analysis was quite potent. And we've begun to leverage this technique actually now in several reanalysis of phase 3 clinical data and emerging therapies, and yielded some important results, which I could share later. So the conundrum here is transthyretin amyloidosis is a progressive disease with a very poor prognosis, especially for late phase disease. And the emerging treatment that we had and still have really prevent progression but don't reverse the disease. And at the time, we struggled with diagnosis because of the need for an invasive approach to diagnosis, and because the widespread use of genetic testing really hadn't penetrated medical care, and I would submit still hasn't really penetrated very effectively. So this manifests in the following data collected by Isabel Lusada, who runs the Amyloid Research Consortium, in which she interviewed either patients or their loved ones if they had passed away. And as you can see, there's a marked delay in diagnosis. 75% of patients need to see at least 3 physicians, need to wait at least 6 months, and receive often an incorrect diagnosis. And notably, cardiologists are the most common subspecialists to make a misdiagnosis, most often attributing patients to have a hypertrophic cardiomyopathy as opposed to cardiac amyloid. So having seen 700-800 cases to date of transthyretin amyloid, I'm just going to briefly go through a few reasons why I think we make a misdiagnosis and highlight some emerging opportunities in the field. First and foremost is this idea that there's a necessity for endomyocardial biopsy. As you're all, I'm sure, well aware now, technetium pyrophosphate and other technetium isotopes, DBT in Europe and HMDP, have been shown to allow for a non-biopsy diagnosis of this condition. These are data that we accrued with my colleague Sabi Bakari back in 2013. When we saw the seminal data actually published by Claudio Rapezzi in JACC almost 8 years earlier in 2005 using DBT scintigraphy. And we showed that this technique was in a population I would submit with a high pretest probability of disease, 97% sensitive and 100% specific. And we used not only a semi-quantitative scoring system rating the degree of myocardial uptake, but also a quantitative, if you will, scoring system using the heart to contralateral ratio. These, I would note, were all based on planar imaging, not using SPECT, and the field has evolved. So using our data and data from centers around the world, we published a consensus document in Circulation in 2016 that suggested that in patients who had phenotypes that were consistent with cardiac amyloid based on echo or CMR, who had a grade 2 or 3 uptake on bone scan, and who had no evidence of AL amyloid, who had an absence of a detectable monoclonal protein. And I'll reemphasize this over and over again. You should not perform a PYP imaging without assessing for monoclonal proteins. The diagnosis could be established. And more recently, society have further validated the idea that we need to confirm myocardial uptake, not on just planar imaging, but by SPECT imaging. And as you'll see, that's often very important. So we can certainly now, I think, facilitate a diagnosis because endomyocardial biopsy is often limited to specialized centers such as transplant programs, which there are not a lot, whereas PYP scanning is available in almost any cardiology practice that has a nuclear camera, of which there are a plethora. And PYP scanning or nuclear scintigraphy is a technique that falls very early in the amyloid cascade. For years, we've been looking at low voltage on an EKG, looking at echo or patient symptoms or even cardiac biomarkers. And while biopsy is clearly the most sensitive and specific test, nuclear scintigraphy is much earlier than many of the other tests that are utilized to make a diagnosis. In fact, scintigraphy is often positive before an increase in wall thickness, echo Doppler abnormalities, and or a rise in biomarkers. These are unpublished data just quickly from our center, in which there's the cohort of patients who were diagnosed by PYP scanning and those diagnosed by endomyocardial biopsy. And you can see that PYP enables a much earlier diagnosis as New York heart class is lower, voltage on the QRS is higher, blood pressure is higher, BNP is lower, everything about the heart is better when you diagnose people by PYP. And of course, therefore, because you're diagnosing them at an earlier stage, they have a significantly increased survival. It's not a therapeutic effect, it's just a time-dependent effect. So there are, however, as PYP is taken off, key causes of misdiagnosis, and I highlight a few of those here. Certainly, some have said not all that glitters is gold, so AL amyloid shown up here can lead to a positive PYP scan, and the assessment for monoclonal proteins is essential. These are unfortunate data from our center that we recently published. Two of our fellows did in JACC cardiovascular imaging, basically showing that the three tests you need, serum immunoelectrophoresis, urine immunofixation as well, and free light chains are only performed, all three of them, in about 40% of patients, all of whom were pretty much seen in the amyloid center. A second cause of misdiagnosis is highlighted up here, which I've kind of enlarged, and that is, as you can see, there's myocardial uptake here, maybe a grade 2 uptake, but the uptake here is in the blood pool in the chamber, not in the myocardium. And so SPECT imaging is essential in this regard. And then there are causes of a false negative, a PYP scan, particularly a mutation called PHE-LU64, which is associated with full-length fibrils causing a mixed phenotype of cardiomyopathy and neuropathy. These patients have echocardiographic evidence of amyloid clearly, but their PYP scans are negative. They don't show myocardial retention. Over now a decade at Columbia, using a PYP scanning, as you can see here, our biopsy rate has remained relatively stable, shown in orange. And I think there's a risk there because we've learned from our oncology colleagues that they can advance the field by having a tissue. And I'm not sure this is a good thing that we're not continuing to biopsy patients. The rate of positives here at 100% was very high, obviously, early on, because we're doing proof of concept studies. But even in the last few years, clinicians, at least at Columbia, and I think at other centers, are leveraging this test pretty well, in that the positive rate is about 30 to 40% in some regard. And testing, of course, has gone off the charts. Notably, as I'll show you in the next slide, a significant portion of what we'll call grade 2 scans turn out to be actually false positives. So this is probably the most important takeaway from this particular paper, in which anyone who had a grade 0 scan, these were scans done in 1 hour, with SPECT used as the quote unquote reference or gold standard, all did not have cardiac amyloid, and anyone in our series who had grade 3 uptake had transthyretin cardiac amyloid. But amongst the patients who had grade 2 scans, as you can see, which were 25, 16 of these actually were false positive scans. And we've seen actually, certainly non-referral centers, patients getting imaged, getting grade 2 scans and being started on tafamidis, when in reality, they actually don't have transthyretin amyloid at all. And that's a problem. So I'm not a big fan of algorithms. Joe Alpert, the editor of the Green Journal, always says between a algorithm and a patient needs to be a provider with a brain. But people always ask, and so these are the algorithms we promulgate, which is a 3-step process. Please always check for monoclonal proteins while or before ordering the PYP scan. AL is a much more deadly condition. Do the PYP scan if it's positive. Always do genetic testing to rule out a TTR mutation, because it has prognostic implications, therapeutic implications, and obviously cascade screening implications for family members. With regard to monoclonal protein testing, all of you should be familiar, I hope, with the serum free light chain assay. Here's an intact immunoglobulin. When you overproduce a monoclonal protein, you have excess kappa or lambda in the bloodstream, and these are the substrates for the development of AL amyloid. This is one of the best biomarkers ever made, because it's not only diagnostic potentially of the condition, it's prognostic. The higher the level, the worse people do, and it is the therapeutic target. We should all develop biomarkers that are ideally this good. And as you can see here, the combination of a serum-free light chain and a serum immunofixation must ask the laboratory to do SPEP with immunofixation, not just an SPEP alone, has a very high sensitivity for detecting the substrate of AL amyloid. Doesn't mean that if an older adult who has a grade 3 scan has a monoclonal protein that they have AL amyloid, because obviously monoclonal gammopathies are quite common, but that a presence of a monoclonal protein does not allow you to use a non-biopsy approach to definitively making the diagnosis. And about 20% of older adults still need biopsy to be performed. So these are the 6 tests that I recommend everyone get on a patient they suspect with amyloid. As we mentioned, assessments for monoclonal proteins, and then an ability to essentially prognosticate based on prognostic scores using either renal function or cardiac biomarkers. And I think you're all familiar with the Mayo AL cardiac amyloid score that nicely risk stratifies patients based on troponin, NT-proBNP, and the difference in the kappa lambda free light chains, a difference of 18 being the cut point. There's the Mayo, if you will, wild type cardiac amyloid score published by Martha Grogan, again in JACC, using NT-proBNP and troponin. And then there's the Gilmore staging system that uses NT-proBNP and estimated GFR to risk stratify patients into early disease, if you will, middle and late. More recently, we've published modification to those staging systems. It's good to note that New York Heart Class still is quite robust, even in transthyretin amyloid, and here's survival data up to 5 years in a cohort of patients at our center that we worked with Richard Cheng and Wayne Levy on, who designed the Seattle heart failure model, quite prognostic. And interestingly, the daily dose of diuretics in milligrams per kilo of Lasix is also quite prognostic. As these patients progress, they usually require, unfortunately, more and more diuretics. And we showed that the Mayo risk score had an AUC here and the UK score, and we added the diuretic or New York Heart Class. It significantly improved the risk profiles of these 2 scores. And so we would promulgate, these are 2 simple additions that can be utilized to better risk stratify patients with transthyretin amyloid. Second, it's thought to be a rare condition. Actually, Pfizer got approval on the basis of that, and I would submit that they kind of won the lottery in some regard. I'm not so sure this truly meets the FDA's definition of a rare disease. So these are data that have accrued. 1 in 7 patients undergoing a TAVR has transthyretin amyloidosis, particularly a wild type. In those with heart failure and preserved EF who have an increased wall thickness of over 12, Pablo Garcia and colleagues have published 13%. In those with HCM, about 5, though in those with HCM over 60, you should always think amyloid. And if you just went on Broadway in New York and took 75-year-olds, probably with no phenotype, and imaged them, we would find about 1 or 2% of patients, which has been done in Europe, have a demonstrable uptake in their myocardium indicative of this particular disease. These are data from our center that we published several years ago with Adam Castano, in which we screened consecutively 151 patients undergoing a TAVR with severe AS. We were interested in the phenotype of paradoxically low flow, low gradient AS, and whether that was all just due to concentric remodeling of the ventricle due to the high afterload, or whether that was due to second hit and concomitant amyloid. Turns out 16% of patients overall, and 1 in, if you will, 5 or so men had transthyretin amyloidosis. Most notably, at the time of doing this, we also wanted to address the issue of should we do a TAVR? And I was the first as a geriatric cardiologist to say that this was going to be a bad idea, that patients with amyloid were going to do worse. But I eat crow, as they say. These are data that were published by James Moon and colleagues looking at the outcomes of patients and clearly showing that those who received, if you will, a TAVR and had amyloid did much better than those who had amyloid with severe AS and did not receive a TAVR. We subsequently published similar data from our center, realizing that we were waiting for these curves to diverge, and they never were going to after a few years. But we did note that there was an increased risk in the amyloid patients after a TAVR of early hospitalizations and making their management somewhat more complicated. And then just published, I think a few weeks ago in JACC, was a large collaboration of data from multiple centers, again, confirming these findings, showing that those individuals who received a TAVR with amyloid did significantly better than those without. And so I don't think we should be withholding a TAVR in patients who have a cardiac amyloidosis, who have significant aortic stenosis. I would note that while 1 in 7 patients with a severe AS has amyloid, in amyloid patients in general, severe AS is prevalent in 2%. So it's actually not a good way to really identify a large cohort of patients who are affected. It's a very small cohort of the overall amyloid population. So this is really an easy diagnosis to make once you think about it. I think I've highlighted that these patients often have heart failure with a preserved EF, particularly without hypertension. The male predominance is interesting and still persisting, I think, in many data sets. They often have right-sided heart failure, so all you have to do is look at their neck veins to see rapid X and Y descent. They have intolerance to ACE inhibitors and beta blockers, so I'll highlight, and there are multiple orthopedic manifestations, including bilateral. And then there are lots of imaging clues, which I'll mention in the next few slides. So there's a clear orthopedic tie to transthyretin amyloid. Turns out lumbar spinal stenosis is, if you will, carpal tunnel of the spine. And we have an NIH-funded small study to investigate this further, but it may be a way to identify people earlier in the course of the disease. Biceps tendon rupture reported by Rodney Falk and others, shown here, or so-called Popeye sign, has a exceedingly high likelihood ratio. So if you see someone who has a biceps tendon rupture and a thick-walled heart, you almost don't even need a PYP scan. It's going to be positive. And then we've shown that individuals with transthyretin amyloid compared to at the bottom here, those with AL, have a much higher risk of having hip and knee replacements, 5 and 3-fold odds ratios compared to AL. So these are orthopedic clues that I urge you to include in your history taking in individuals. They're quite helpful at identifying the underlying phenotype. The echocardiographic clues are shown on these still frames. There's increased wall thickness. It's always thought to be symmetric, but by MRI, I can tell you Maria Fontana's data suggests it's often not symmetric. In fact, only 18% of patients by MRI have symmetric increases in wall thickness. So don't let asymmetric septal hypertrophy let you down the road of hypertrophic cardiomyopathy. They often have valvular thickening, intraatrial thickening. Early on, they have diastolic dysfunction that progresses to a restrictive phenotype. A pericardial effusion is often seen. And if you miss the diagnosis, they often progress on to a systolic heart failure. MRI is certainly a technique that brings awareness to this disease. Shown here are MRI from a patient with a concentric increase in wall thickness and diffuse delayed enhancement. And the pattern, I don't think, is specific. So I wouldn't rely just on the subendocardial enhancement. Any pattern can be seen in amyloid patients. And MRI has certainly increased the referral network, though doesn't provide a definitive diagnosis. I don't tend to leverage it that frequently. And of course, this phenomenon that's seen on speckle strain echo of preserved apical function or sparing, which is the opposite of what you'd see in coronary artery disease, is sensitive and specific for amyloid, though also not perfect and seen in particularly Afro-Caribbean patients with chronic kidney disease. We've seen it often. So I think the most important reason, though, that we've gotten interested in this disease is not because we can diagnose it, not because it's more common, but rather now we have really effective treatments, especially if diagnosed early. So the management in general of amyloid is shown here. Maintaining euvolemia is difficult. As you can imagine, these patients are very low labile. They have on the advanced stages, lower blood pressures. We often use bioavailable loop diuretics, bumetanide and torsemide, along with aldosterone antagonists. Certainly, dihydropyridine or non-dihydropyridine calcium channel blockers are contraindicated, and you can see why. Verapamil could bind avidly to amyloid fibrils, as does PYP, because it's a calcium-binding isotope. Not so sure digoxin is as contraindicated as everyone makes it out to be, and we can talk about that if people are interested. As I mentioned, these patients have a fixed stroke volume, that doesn't modulate, and they really need their heart rate response to augment their cardiac output. So they definitely don't like high-dose beta blockers often as the disease advances. And we actually have some data that deprescribing beta blockers actually promotes survival in these patients. We're trying to organize that data more formally. It's an interesting phenomenon in the geriatric literature, the idea of removing medicines. One of the main messages is atrial fibrillation is incredibly common. I see Vivek Reddy's on, and I work with him and Bill Wang. But you got to anticoagulate these patients, irrespective of their CHA2DS2-VASc score. And over time, these patients unfortunately progress to hypotension. Regarding devices, certainly pacers have much more role in ICDs, in transthyretin amyloid. and we can talk offline, or after, but BiV pacing probably has, I believe, a significant role. And we're trying to work with one of the device companies for a actually randomized trial of BiV pacing in cardiac amyloidosis. These are unpublished data from my colleagues in Heidelberg showing survival on the y-axis, and these are the patients who didn't get a beta blocker in blue, and these are the patients with amyloid who got a beta blocker. So if you want to kill your patient with amyloid, it looks like you give them a beta blocker. And similar, but not as robust data with regard to ACE inhibitors. So these are patients who get standard medical therapy easily for heart failure. AFib, as I said, is quite prevalent. It's about a third in large series. In the ATTR-ACT trial, half of the patients. In our experience, almost everybody gets AFib over time. And again, whether you use a NOAC or warfarin, you need to anticoagulate these patients, and both seem to be reasonably effective. These are data from Maz Hannon, the Cleveland Clinic, showing that wild-type patients have more AFib, probably due to their age, than hereditary patients, that it increases over time with the stage of disease, that it's not associated in the bottom panel with an increased mortality. And if you're going to think about interventions, in my opinion, you want to do those interventions to maintain sinus rhythm in patients with early stage disease. They're not very effective, and this is only at 30 days efficacy. So I don't advocate for aggressive ablations in amyloid patients with advanced phenotypes. Again, we're focusing on TTR today, but AL amyloid is an incredibly important disease. It's a toxic and infiltrative cardiomyopathy, and you need to work carefully with a hematologist, as I know you have experts there. The new kid on the block that's really garnered the most stardom is daratumumab, a monoclonal antibody against CD38 that's uniformly expressed on plasma cells. And this drug is quite amazing. The Andromeda trial, which I had the privilege of being on the steering committee for, did meet its primary endpoint. It will likely be the first therapy ever approved by the FDA specifically for AL amyloid. Every therapy we use for cardiac AL amyloid is off-label. It's a myeloma therapy. And this drug was associated with a much higher hematological response and complete response, and better organ responsiveness. You made the heart better, the kidney better, and the liver better. It lowers light chains very expeditiously, and I think will become the standard of care along with Cytoxan, Velcade, or bortezomib and dexamethasone. So transthyretin amyloid, just to the next 15 minutes or so wrap up. Here's the pathogenesis. For those of you who don't know, transthyretin is also prealbumin. It's a homotetramer, or a protein produced in the hepatocytes on chromosome number 18. It's 127 amino acids, and each monomer of TTR transthyretin links together at the dimer-dimer interface. In the setting of aging or mutations, the protein becomes unstable, dissociates into monomers, and deposits in the heart, causing a cardiomyopathy, or in the nerves, causing a polyneuropathy. And in reality, this dichotomization, I think, is a big mistake. Most patients have, to be honest, a mixed phenotype. And we're even observing that some wild-type patients have particularly a cardiomyopathy. In fact, almost universally, we've seen neuropathy post-heart transplant when we replace the heart in a wild-type patient, and God forbid, don't treat their amyloid. The protein ends up in their nerves. And so that's a big problem post-organ transplantation. These are the seminal events that have led to the development of tafamidis, and credit is all due to Jeff Kelly, a protein chemist at Scripps, who you can see back in the early 2000s in Science, discovered that there were patients in Portugal who had the V30M mutation. This is a mutation where methionine replaces valine at the 30th position. It leads to a neuropathy in people of the age of 30 years of age. It's nearly fully penetrant in Portugal, and they discovered grandparents who had the mutation but didn't have disease. Teresa Coelho was caring for these individuals, and Jeff sequenced their TTR gene and found that they had, in addition to an amyloidogenic mutation, they had a trans suppressor, if you will, mutation, T119M, that basically on their second allele led to stabilization of the protein. So the protein falls apart in the setting of a V30M mutation, and in the presence of T119M, the protein does not dissociate into monomers. And so Jeff thought this is potentially druggable, and that's what led to the hypothesis behind tafamidis. So now we have multiple therapeutic opportunities, and while tafamidis is the only FDA-approved drug, there are certainly other therapies that we have a lot of hope for, and I'm quite, I would say, sure will be effective. Obviously, there's drug silencers, patisiran, inotersen, and next generation that are in late phase clinical trials, which I'll mention. There are stabilizers in addition to tafamidis. There's a diflunisal, a non-steroidal, and AG10, which I know Sumit and myself are involved in the phase 3 trial that's fully enrolled. These stabilize the protein and prevent progression into monomers and oligomers. And then there is fibril removal agents, which, to be honest, I've seen fail and fail over and over again. And as a result, I'm not very confident about their efficacy, though they're continuing to be utilized in clinical trials. Notably, I would also note that the first attempt at CRISPR is being done for transthyretin amyloid, and the first infusion occurred in London already, in which silencing a TTR gene once with a single infusion for the rest of your life may really be an important therapeutic approach for this condition. So tafamidis, as you know, was approved. I'll show you the phase 3 data. I mentioned cost. And then for cardiomyopathy, there's also diflunisal, which we use, especially as a highlight in early phase individuals who either, God forbid, can't afford or access tafamidis, or who are really early and who really don't have a phenotype yet, but are high risk for development of disease. So with Justin Grodin at UT Southwestern, we wrote this editorial a few years ago, and I think it's illustrative about how this disease develops and important to think about. Amyloid is probably depositing in individuals in their 40s and 50s, and it deposits over time, and eventually there's not much more depositing. There may be secondary effects, cellular apoptosis and inflammatory events. Patients with this condition have a rise in their biomarkers, with troponin coming after BNP. Their ejection fraction is pretty stable over time, but declines, albeit in latter phases, as does their renal function. And concordant with the New York Heart class are the staging systems that we talked about, and increase in hospitalizations are quite dramatic. In fact, the data suggests that in the latter 3 years of life, these patients have a median of 17 median hospitalizations. They're literally hospitalized like every few months. And so I would submit there's a phase where therapy at this point is probably too early to be administered. I'll highlight cases that show that. A big phase where therapy is just right, and a phase where it's too late. And so this is my 3 little bears analogy to the application. Too early, just right, and too late. And I'll walk through these. So this is a common patient we'll see who's an elderly gentleman, unfortunately. He's had multiple previous hospitalizations just in the last 6 months. He's frail and he's in a wheelchair and non-ambulatory. He's hypotensive, as you can see, and he's hypotensive while taking midodrine. He's markedly volume overloaded with a big liver, 3 to plus edema. He's got JVP. He's got reduced ejection fraction with RV dysfunction. His BNP with TTR is nearly 10,000, and his EGFR is very low. And this person's too late because we didn't include this person in the ATTR Act trial, right? People had to walk. People had not to have class 4 symptoms, and they had to have preserved renal function and good nutritional status. We did include people who had class 3 disease, and across 11 pre-specified subgroups, tafamidis was superior to placebo except for 1. And that was even in individuals with New York Heart class 3 who lived a little bit longer. They had an increased risk of hospitalizations. And I attribute this in part because when the phenotype is quite advanced, tafamidis, because it prevents progression, doesn't really do anything. So if these patients have dietary indiscretion or an episode of AFib or something, they decompensate pretty easily. And so I think you have to be cautious about applying this therapy to people who are pretty advanced. So that's a difficult conversation to have. Here's a patient who I think is too early, but interesting. She has a mother and a father who are both allele carriers, and she's homozygous. So she has, however, no phenotype. She has no low voltage or Q waves. Her blood pressure and exam are normal. Her echo is pretty normal too, with a normal strain, no apical sparing, no increase in wall thickness. She has normal biomarkers, a normal renal function. Notably, her prealbumin's a little bit low, and we see this often in allele carriers of the mutation. It's a good screening test, I can tell you, to identify people. And there was just a report, I believe this week in JAMA Cardiology, that Sanjay Shah wrote a nice editorial about, describing the potential utility of prealbumin as a screening test. So I already highlighted in this patient, I believe scintigraphy would be useful, because even though she has no phenotype, if her scintigraphy showed uptake, I would be concerned. And you can see here, here's a scintigraphy in 3D showing her sternal uptake in bones and really no myocardial retention of the isotope. And so in this particular individual who's early and young, who's at risk for disease, we could debate, but I might offer her diflunisal, a non-steroidal anti-inflammatory. And we do this often with allele carriers of a mutation, though obviously we don't know of the penetrance of the disease. And so that might be, some would argue, premature. There's lots of people, though, I think, who are just right. And here's a gentleman who would be perfect for tafamidis, I believe, 64 years old, class 2, has a biceps tendon rupture, has an increase in wall thickness, but not tremendous, has a global longitudinal strain that's reduced, an elevated E prime, has a grade 3 scan, SPECT confirms myocardial retention, has a high HCl ratio, and has early disease with no monoclonal proteins. And some might say, especially insurance companies, well, he didn't meet the criteria of the ATTR ACT trial. His NT-proBNP is only 400, and the entry criteria were 600. Well, that's illogical, I think, right? You're not going to wait for this gentleman to get sicker, knowing how the drug works. And so the ATTR ACT trial enrolled 441 subjects, randomizing 60% of the subjects to tafamidis versus placebo. The average age of the patients was 75. They were predominantly, almost exclusively, males, with a 75% having wild type and only a quarter having a variant disease. And the patient population included individuals who had EFs of about 48, with markedly increased wall thicknesses, reduced global longitudinal strain, elevated troponins and NT-proBNPs. And I point out stroke volumes that are of the lowest seen in any cardiomyopathy. These are not the index stroke volumes. These are the absolutes. So the LV stroke volume index was in the 25 range. And I often wonder, how can the patient have such a bad echocardiographic phenotype, yet only be NYHA class 2 in 60%? And that's because this disease is very slow and indolent. And I think we have a huge opportunity to make the diagnosis. The data from tafamidis was quite effective. Using the Finkelstein-Schoenfeld method, a robust p-value. Probably most important from the trial was the 13% absolute reduction in mortality with a high win ratio. And similarly, we reduced the risk of cardiovascular hospitalizations by about 30% compared with placebo. We reduced the risk, by the way, of all-cause hospitalizations as well. And we never expected this, but even using traditional Kaplan-Meier in a relatively small trial, we saw a statistically significant effect after 18 months. So there's a number needed to treat of about 7.5 patients over 2.5 years to prevent 1 death, and an NNT of only 4 patients to prevent 1 hospitalization. So these are kind of amazing efficacy. Having said all that, there's a big dilemma, and that is at the current cost, to prevent 1 death would cost $4.2 million, and to prevent 1 hospitalization, given the list price, would be $900,000. So we have a dilemma here with regard to costs. Tafamidis did make people generally feel better, but slowed the decline in the 6-minute hall walk and in the KCCQ significantly and early after 6 months. And again, these are unpublished data, but in the ATTR ACT trial, there were only 37 patients out of 441, so less than 10%, who were NYHA class 1. But the relative risk reduction, despite the wide confidence intervals here, the relative point estimate was 64%, 39 for class 2, and only 16% risk reduction for class 3. It works much better when administered earlier. And we're seeing hazard ratios now of greater than 50% in reduction in mortality compared to historical controls. There's another stabilizer on the block, AG10, which mimics the T119 mutation. These are data published by Dan Judge, myself, and others based on the phase 2 trial. Interestingly, this is an interesting biomarker. That is, if you give tafamidis or AG10 within 30 days or 2 weeks even, you'll see an increase in prealbumin levels that are quite robust. And with tafamidis, these are in the 40 to 50% range as well. higher in women than in men, higher with allele carriers of a mutation. And whether this is a biomarker that can establish efficacy is up in the air. There are emerging other therapies that use, again, silencing techniques, the small interfering RNA or an antisense, and the therapeutic hypothesis behind those is shown here. You're producing a wild type or mutant protein that becomes unstable. It deposits in the forming amyloid in the organ and causing the phenotype. And by reducing the unstable circulating tetramers, you could prevent organ deposits and ideally stabilize or maybe even reverse the phenotype. And the data from a sub-study that we published with Scott Solomon in Circulation shows that in those receiving patisiran, NT-proBNP levels decline slowly over time, as early as 9 months of therapy, where those receiving placebo increased significantly. And there were significant effects in the quote-unquote cardiac subgroup on wall thickness, strain, end diastolic volume, and even LV mass, indicative of the fact that patisiran may be having an effect. And there's a recent report from the London group demonstrating some effects of patisiran on extracellular volume just recently in a JACC cardiac imaging. Similarly, antisense, and this is Tegsedi, had similar, albeit less robust effects on cardiac structure and function. So these are trials that either are enrolling or have completed enrollment. AG10 is an oral stabilizer I mentioned. Enrollment is complete. Patisiran is being studied in what we call the Apollo B trial, which is nearing the end of enrollment. And then we have 2 silencer trials. Ionis has a sub-Q silencer, and then there's vutusiran, son of patisiran, being studied in Helios B. And so these are the trials. I know that Sunit is conducting several of them. And if you have subjects, feel free to reach out to him. If you're not conducting any of them, we're involved in each one of these trials here at Columbia. So I'll conclude by saying I think TTR amyloid has been described as my Italian colleague, Claudio Rapezzi, as the great pretender. It's a challenging and fascinating disease. It's mysterious. It's definitely not as rare as you and I supposed. It's very easy to detect if you think about it. If you never think about it, you'll never diagnose it. And it's definitely a treatable condition. Just to highlight, I think the field needs to now move toward earlier diagnosis. And we were privileged, and I am privileged to work with Rick Ruberg, my co-PI in Boston, on this NHLBI-funded study called SCAN-NP, whose broad aim is to change the approach to this disease, which is devastating in its latter phases, by screening and early diagnosis. And so this is a prospective cohort study in 800 participants, all of whom are either Black or Caribbean Hispanic, and they all have to have heart failure. It will be the largest cohort study of minority patients with heart failure that NHLBI has accrued, can be leveraged for all sorts of other studies if people are interested. And we phenotype patients in order to evaluate the prevalence of the disease and also look at the prevalence of the V122I versus wild type disease and the progression of those who have the disease in a year's time. So in summary, I think in a brief decade, we've gone from a rare disease to one that's appreciated by many cardiologists. You're seeing it every day or every week in your practice. Please look for it. One that required an invasive biopsy that now can be diagnosed non-invasively, and one that had no treatment to one that has a plethora of emerging therapies. And so again, I thank you for your time and happy to answer any questions.
Dr. Maurer, it's Sumit here. Thank you again for that amazing talk. I wanted to ask about some of the silencer technology. You know, you hit on some of the in terms of improvement in wall thickness or strain values, inotersen didn't necessarily accomplish that as much as, say, patisiran. And do you think that's perhaps maybe lack of appropriate hepatic uptake of the silencer? And do you think that'll be addressed with the next generation compounds that are such as vutrisiran or XCLR using GalNAc or the ASPGR receptors to improve hepatic uptake?
Yeah, I actually think that the problem is not with the uptake of the current generation. I do agree the next generation will probably be more effective, easier to tolerate, at a lower dose. I think the problem is this hypothesis that everything's in the wall thickness. I mean, remember, you can get a lot of amyloid depositing in your heart before the wall thickens. So I didn't share this yet because it's just recently completed, but we've gotten access with obviously Alnylam's approval to the Apollo B data. And at the beginning of this talk, I showed you pressure volume analysis, which can be done non-invasively if you have high quality echocardiographic images conducted in a core lab. And Scott Solomon was the core lab. So in collaboration with Scott, we've performed pressure volume analysis on the Apollo data. And we didn't actually look at the quote unquote cardiac subgroup. We looked at all comers. And I can tell you in Apollo, almost everybody in that trial, even if they have a bad neuropathy, still has evidence of a cardiomyopathy. It's a minority of patients. And I think that we've broken up the disease into neuropathy and cardiomyopathy for clinical reasons, because that's what we were seeing. We were cardiologists. We don't know how to do a nerve exam. We didn't really appreciate there could be a subtle neuropathy. And the neurologists, the opposite. And I also think for regulatory reasons based on FDA. But I can tell you that pressure volume analysis, which is much more sensitive, demonstrates tremendous effects of patisiran in all comers on cardiac structure and function. So I think these drugs are really going to work. In fact, they may be superior to actually stabilizers in some regard. And so there'll be lots of questions we need to address. Which is better? Which one should we give first in sequence? How do we switch patients if they're not responding? Lots of, I think, clinical questions. Obviously, we need the primary data. The trials also are a little limited. If I had my druthers, I wish they would have designed a trial in which they had everyone getting a silencer, everyone getting a stabilizer, and a group that was getting combinational therapy. They didn't choose to design them that way. And I think that's probably a limitation of our, if you will, quote unquote, regulatory process. We promote in the United States that we have a competitive environment. It's actually totally anti-competitive. We don't actually rapidly develop new therapies too quickly, but that's an aside. So I think that to your point, though, I would strongly encourage people to participate in these upcoming trials. They have a huge potential.
Matt, this is
Hi,
Fred
Matt.
Sherman.
Hi, Matt. This is Donna. A wonderful talk. Thank you so much for that overview, and thank you for all you've done to contribute to this field.
Thank you, Donna, for mentoring me. You're amazing. So
I have two questions. One is the patients with amyloid that you transplant. Are you putting them on tafamidis now?
Yeah.
And if so, how do you get it approved? And the second question is, do you ever see patients with amyloid and hypertension? Because I've seen a couple of patients now that clearly have cardiac amyloidosis and yet are quite hypertensive.
Yeah, so I think this, to answer the second question first, we make it really, in this talk, I've made it really easy. Donna, you're completely correct. I mean, the hard part for a general internist, right, is, or a general cardiologist is, these patients get hypotensive when they have advanced disease, but early on, there's definitely an overlap. And, it's going to be a challenge. I think that's why the level of suspicion has to be somewhat high. And we need to develop algorithms. I swear, I think the easiest thing for clinicians to do is try to look at the left ventricular voltage across the 12 lead of an ECG and also look at the wall thickness. Christina Quarta did her PhD thesis and she published this years ago, but just quickly, there are 12 leads obviously to an EKG. The average voltage is 10. If you add them all up, that's 120. You divide it by the usual wall thickness, which is 10 millimeters, you get a number of 12. I swear, if you start looking at the 12 voltage divided by the wall thickness and the number is 7 or 8, even if you're hypertensive, that's a very good clue that there is amyloid there. And that's kind of the cut points. I can send you the numbers. Back to the question about transplant patients. I think we've done them a disservice, Donna. I'm feeling very guilty. We've transplanted patients knowing that, the disease could still come back. We didn't think it would, and it is coming back. And we have data, Martha Grogan's published data, we presented it, showing that all of these patients who get transplanted will develop a phenotype subsequently. So we need to treat them with something. We've asked the silencer companies to do a trial with, for example, on Patro. We couldn't get them to budge, and they didn't ultimately agree. We are prescribing and have been successful at getting them silencers through insurance. It takes quite a bit of wrangling, but you can get it. And we have interest now with Pfizer in a open label post-transplant study But I don't think we can wait too long. So I would urge you to try to apply. I think that actually success may be higher than you think about getting people. I think that probably a silencer may be better, again, post-transplant than a stabilizer, but I think we should do something.
Yeah, I've been using difluzinol until we can get the tafamidis.
Yeah, obviously that's problematic with TACRO and renal insufficiency and all.
Dr. Maurer, just to piggyback off of Dr. Mancini's question, do you worry about the use of inotersen and the rare risk of thrombocytopenia or glomerulonephritis in a post-transplant patient? Because I just feel like we're so worried about those patients. So I always try to, if I'm going to use a silencer in a post-transplant patient, I veer towards patisiran.
Yeah, great. I would think that, that would be the first line agent, despite the fact that it's a little more cumbersome. And in all the patients that we've treated with silencers, it's always been on Patro or patisiran. Someone else had a question?
Yeah, Matt, this is Fred Sherman in geriatrics.
Hey, Fred.
Hi, how are you? So is there any genetic relationship between TTR and aortic stenosis that we see in old people? Is there any genetic relationship?
Yeah, it's a good question about, the quote unquote marriage or overlap. People are investigating further. My own bias, I hate to say it, is I think these are just two age-related conditions that occur, but that may be, I've been wrong so many times, I may be wrong again. Is there a biology? Some think, why, for example, is the heart and, ligaments affected? Those are tissues that have a lot of motion. Some argue that there may be some shear stress related to aortic stenosis for prealbumin and may actually promote fibril degradation, production of monomers or oligomers and cause the phenotype, though that is an area of investigation. But I don't think we know that there's any per se genetic link. And again, the overlap is pretty high with regards to those undergoing a TAVR having amyloid, but the opposite isn't that true. So I always urge people, if you want to find patients with amyloid, I wouldn't go to your TAVR program. You're only going to find, 1 or 2% of all the people with amyloid that way.
Thanks.
Hey, Dr. Maurer, it's Noah Moss. Quick question. You touched on it briefly. What's your approach to the children of those familial TTR patients? I know you mentioned you would use. How do you further work them up, follow them? What testing are you doing? So
for allele carriers of mutation, it's a great question. Who should be screened? Obviously, first-degree relatives need to be informed that they could be at risk. Yeah. This disease has an age-dependent penetrance, and so screening people who are 25 doesn't, to me, make a lot of sense unless they're actually planning to have a child and they want to do pre-implantation genetic testing. That's the only reason that's come up in my practice for people that young to want to get tested. In general, there's no good data, but expert recommendation, there was a paper published in Amyloid, suggests that you should screen individuals who are first-degree relatives about 10 years earlier than the program first presented. That's when you should start. Obviously, if they have the allele, if they don't need further screening. Obviously, you need to inform patients about, about the risks of, thankfully they can't lose their health insurance, but life, disability, and long-term care insurance still in this country could be at risk, and so that's a problem. And then, what do? We at our place, after finding an allele carrier, we try to intensively evaluate them, including PYP scanning. If they don't have any phenotype, we still have a discussion with them about what's the role of therapy. You're not going to get, to Donna's point, tafamidis approved for someone who doesn't have disease, but you could obviously give them diflunisal. And that's an individualized discussion with a patient, shared decision-making, whether they want to take a medicine chronically, to theoretically prevent the development of disease. We don't have any data, and it's a drug that's taken for years. So certainly once people have evidence of a phenotype by PYP, for example, which I think will be one of the earlier things would be even PET scan, then I think it behooves us to begin to institute treatment, whether they have symptoms or not. Because we have data, by the way, we submitted from 6 centers showing that those who are NYHA class 1 with low biomarkers under 600 in about 120 patients over 3 years, almost all of them develop heart failure. And there's a significant morbidity and mortality. So having this disease is not a good thing, right? You don't want to sit on it.
Yeah. And what's your threshold to biopsy these patients?
Oh, pretty high. I can tell you a quick
Okay.
story. One of our expert, cardiology fellows who went to practice in New Jersey sent me a patient who was, to Donna's point, 57, African-American, hypertensive. He said his echo looked like amyloid. He didn't look clinically like he had amyloid. He had an increase in wall thickness. His PYP was a grade 1. He had a V122I mutation. So we biopsied him despite having a negative PYP, and he had amyloid, and we started him on treatment because we believe that that's the right thing to do, and he got tafamidis. So I think you have to think about individual cases. That's where the algorithm kind of can fall apart. And if you have a high index of suspicion, I think biopsy has a very big role to play.
Are there any studies ongoing looking at treating these patients early with tafamidis, or because I know it's difficult getting the approval, but are there any studies looking at it?
The data that we have may put that to rest. In the patients that the 119 I mentioned, those who got stabilizers had a mortality reduction of more than 50% over the 3 years.
Right.
Even people who are early class 1, some of them, are passing away. And now the debate is, I asked my colleagues, let's make sure they're passing away from amyloid heart disease, not some other sundry thing. But the way the drug works, it would be very surprising to me that earlier therapy wouldn't be effective.
All right, thanks.
Okay, I guess everyone has to get back to work, as they say.
Matt, one last question. If these people have the potential their whole lives, why does it take so long to manifest? What happens when they get older that all of a sudden it demonstrates its presence when the potential has been there their whole lives?
That is one of the $6 million questions. The other one is, why, if the protein's made in the liver, does it get in the heart? What's the tissue tropism? Short answer, Marty, is I have no idea. I can throw out some ideas, one of which is maybe there's an epitope that's exposed as we get older. Maybe it has nothing to do with the degree of misfolded proteins, but we all are misfolding, and there's some kinetics that happen in contractile component. But honestly, that's an outstanding question that I have unfortunately no insights to, but I'd love someone in the basic science world to try to recapitulate phenotype in an animal model. I just don't know why this has an aging effect.
Again, thank you, Matt, for such a wonderful talk. I'm sure it'll generate a lot of questions further that I can forward to you. But again, thank you very much. Have a great day.
You too, guys.
Thank you, everyone.
Thank you, Dr. Maurer.